You know what's worse than getting smoked by your platoon sergeant at 0430? It's walking into your shoulder C&P exam with absolutely no idea what's about to happen and then watching your rating get buried before you even sit down. I'm Dr. Marshall Bahr, and today I'm going to walk you through exactly what happens in your shoulder C&P exam. Not the sanitized version, but the real one. Look, I get it. You file your shoulder claim, you get a letter in the mail or a phone call scheduling your compensation and pension exam, and then you spend the next 2 weeks trying to figure out what the hell is going to happen in that room and what they're going to ask. I'm a physician and I've done these exams, right? I'm also an Army Ranger and a combat veteran, which means I have a unique perspective because I've been on both sides of the table. I've sat in that room as a patient wondering if the examiner actually gave a damn about my shoulder that's been screaming at me since I spent years humping rucksacks that weighed more than some people's children. And here's what I wish someone had just told me before my first C&P exam. Knowledge is power. When you know what's coming, when you understand what the examiner is looking for, when you can speak the VA's own language, you stop being a victim of the system and then you start controlling your own narrative. So what I want to do today is break down every single thing that's going to happen in your shoulder C&P exam. What they're testing, why they're testing it, what those measurements actually mean. Most importantly, how to make sure your pain, your limitations, and your reality actually make it into the record correctly. Because here's the hard truth. The examiner isn't trying to screw you. That's not what they're there for. But they're also not trying to save you. They are documenting what they see in the records. And if you don't show them the whole picture, they can't write it down correctly. First things first, who actually is doing your exam? Well, your CP examiner will typically be one of three people, either a medical doctor, like an MD or DO, a physician assistant, otherwise known as a PA, or a nurse practitioner, which NP is for short. All of them are qualified healthcare providers. The VA doesn't let just anyone do these exams. Now, here's what you need to understand. Your examiner is not a VA employee trying to save the government money. Most CP examiners today are done by third-party contractors, companies like QTC, LHI, VES. These examiners work for private third-party companies that the VA contracts with. That doesn't mean they're on your side, but it also doesn't mean they're against you. They are there for one specific reason: to document, to measure, to record what they find. What they will not do is they will not give you a diagnosis right there in that room. They will not tell you what your rating will be there. They will not prescribe you medication. They will not refer you to a specialist, and they are not there to answer questions about your claim status. Their only job in that moment is to fill out that disability benefits questionnaire, otherwise known as the DBQ. And then what they do with it is they send that back to the VA. And here's the part that trips up most veterans. The examiner has probably never read your entire VA file. It's a hard truth. They might have read a summary, but they haven't spent hours reading through your entire service treatment records, your buddy statements, your private medical records. Now, should they have? Yes, but they're overburdened, overworked, and sometimes they don't. They know what the VA told them to look at that moment, but that's about it, which means you need to fill in the gaps for them. Now, let's get into the actual DBQ of the shoulder. It has 17 sections. Now, I'm not gonna read every single checkbox because you didn't sign up for a root canal today, but I am gonna walk through the sections that will actually matter for your rating. So section 1, very important, it's the diagnosis. This is where the examiner documents what is actually wrong with your shoulder. If you don't have a diagnosis, do not file a claim. What they're doing is, in this section, they're gonna check boxes and look for things like, do you have a shoulder strain? Are you diagnosed with a rotator cuff or tendonitis injury? Do you have impingement syndrome? What about bursitis, labral tears, arthritis, any instability or dislocation? Here's what matters. They need to put an ICD-10 code and a date of diagnosis. If you were diagnosed with a rotator cuff in 2018 and it's been documented in your medical records, that needs to go in the section. If they diagnose you today for the first time, that also goes in this section. The diagnosis determines which rating criteria the VA will use. So if your shoulder problem is actually a rotator cuff tear, but the examiner only writes down shoulder strain, you might not get the rating you deserve. This is why you bring documentation with you. This is why you tell your story clearly. articulate your story. The section 2 of the DBQ is what we call the medical history section. This is where the examiner will ask you to describe in your own story the history of your shoulder condition. What this is not the time to be humble, okay? Do not be tough. They really want to know, when did it start? Did it happen during your deployment to Afghanistan in 2012 when you were a paratrooper? How did it start? You know, did you feel a pop in the shoulder during a bad landing? Did the pain start immediately and never went away? What has it been like since then? Like, I've had chronic pain, reduced range of motion, difficulty sleeping, and trouble lifting literally anything overhead. Then what they should do is ask about flare-ups. Does your shoulder have flare-ups? Yes. The answer is yes. Even if your shoulder hurts every single day, you still have flare-ups. Days when it's worse than the baseline. So what you need to tell them is how often these flare-ups happen. Are they happening weekly or after certain activities? How long do they last? Are they hours, minutes, days? What is triggering the flare-ups? Is it lifting, any overhead work, barometric weather changes, stress even? What happens during a flare-up? Does it affect your ability to lift your arm up? Does there sharp stabbing pain? Can you not sleep anymore? Do you need to rest and ice it? These are the things they want to know. And here is the critical question that they will ask. Does your shoulder condition cause functional loss or functional impairment? The answer is yes. Functional loss means, what can't you do because of your shoulder? I want to give you some examples of functional loss. These are things like, I can't lift my kids anymore. I can't wrestle with my kids. I can't reach into the back seat of my car. I can't put dishes away in the upper cabinet to help my wife out. I can't work out the way I used to. I can't wash my hair without pain. Or I can't sleep on that particular side because the pain is so bad. I need you to write these down before your exam and make sure to tell the examiner, because when you tell the examiner, they are supposed to document it. All right. Here's where the magic really happens, or where it falls apart for some people. The range of motion testing. This is the most important part of your shoulder C&P exam, because this is what determines your actual rating. Let me give you the VA rating scale for shoulder limitation of motion. It is diagnostic code 5201. They look at your dominant arm, and then they look at motion that is limited to 25 degrees from your side. That is a 40% rating. Then they look at motion limited midway between side and shoulder level. That's 30%. Then they look at motion limited at the shoulder level, which is 20%. And then any painful motion at all is a baseline of a 10% rating. Now, that was for the dominant arm. When they are looking at your non-dominant arm, the ratings change a little bit. They decrease. They look at motion that's limited to 25 degrees from the side as a 30% rating. They look at motion limited midway between side and shoulder level as 20%, motion limited at shoulder level as 20%, and again, any painful motion, even in the non-dominant arm, is a minimum of a 10% rating. So what does this all mean? What does it actually mean? Well, it means the examiner is going to measure 4 specific movements for your shoulder. What they look for first is what we call flexion, which is the forward motion of your arm. So normal is 180 degrees, straight up over your head. Raise your arm in front of you as high as you can, like you're pointing at someone at the ceiling. The next is going to be called abduction, abduction. It means lifting the arm out to the side. So the normal is 180 degrees, straight up to the side. Raise your arm out to the side like you're doing a jumping jack. So you just come straight up, 180 degrees. The third movement is what we call internal rotation. This is normally what they look for is a rotation of 90 degrees. That's what's normal. And what they're going to do is say, bend your elbow at a 90-degree angle and rotate your forearm towards your body. So you've got it at a 90-degree angle, and they just tell you to rotate it towards your body. That movement right there, that is internal rotation. And normal is all the way, 90 degrees. The next and the last movement is external rotation. Again, this is very similar to internal, it's just the opposite way. And the normal is 90 degrees. So again, how to do it. Bend your arm at a 90-degree angle, and they're gonna have you say, rotate your forearm away from your body. So this way. So you should be able to internally rotate 90 degrees and external rotate 90 degrees. That is normal. So how do they measure this? Well, they use a tool called the goniometer. The examiner will use this tool, and it looks kind of like a protractor with two arms. And by law, which is in the CFR 38 code, part 4, the VA requires the use of this tool for all range of motion measurements. They cannot just eyeball it. One arm of the goniometer stays stationary, and the other arm follows your movement. Where it stops, that's your measurement in degrees. Here's what you need to know. The examiner will test your range of motion 3 ways. Active range of motion, where you move your arm as far as you can before it hurts. Passive range of motion, which means the examiner moves your arm to see if it goes any further without your muscles doing the work for you. And then after repetitive use, you'll do the movement at least 3 times to see if the pain gets worse or the weakness gets worse. And then the pain question. At every moment and every movement, the examiner is going to ask, do you have pain? Listen to me very carefully. Tell them the moment you feel any pain. I'm dead serious. The second you feel discomfort, pain, pulling, catching, grinding, you say it out loud. I feel pain right there. The examiner will document where the pain starts. That matters for your rating. Do not tough it out. Here's what veterans do wrong. They tough it out, right? They push through the pain because they've been conditioned their entire military career to not complain, to not be a weak person, to not show weakness. It's the wrong mindset for a CMP exam. The examiner can only rate what they observe and document. If you're grimace, but you don't say anything, they might not catch it. If you say it's fine when it's not actually fine, they'll write down no pain reported. And then you're screwed. The VA has a rule called painful motion. Under the CFR 38, it says any joint with painful motion is entitled to at least a minimum compensatable rating. But they have to document the pain. So when they move your shoulder and it hurts, tell them. When they ask you to lift your arm and you feel a sharp catch, stop and tell them. Now what about functional loss due to pain? After they measure your range of motion, they're going to ask, is any limitation of motion specifically attributable to pain, weakness, fatigability, or incoordination? Answer is yes. If your shoulder stops at 90 degrees of abduction because it hurts, to go further, that's the limitation due to joint pain. If your shoulder can physically move to 100 degrees, but it's causing stabbing pain and you can't do it repeatedly, that's functional loss due to pain. So what you need to do is tell them, I can't go any further because of the sharp pain. If I push past this point, I'll be hurting for days, or this movement causes pain that limits what I can do at my job. Now, repetitive use testing, this is the thing that nobody warns you about. And here's where the DBQ gets really interesting and where the VA is trying to understand your real functional limitation. After your initial range of motion, the examiner will ask you to repeat certain movements at least 3 times. Why? Because the VA knows your shoulder might move okay once, but after repeated use, like during a workday, it might get worse. This is section 3B of the DBQ, observed repetitive use of range of motion. They want to know, does your range of motion decrease after you do it 3 times? Let's say your first attempt is flexion 120 degrees, but after the 3rd repetition, you can only get to 100 degrees because the pain and weakness is worse. That's documented as additional loss of function after repetition, and that can bump your rating up. So when you do repetitive testing, don't try to be a hero. If it hurts more on the 3rd stop, the 3rd repetition, if your arm is fatiguing, getting weak, if the range of motion is less, just say it. Now, here's the next level. It's section 3C, and it asks about repeated use over time. Not just 3 reps in the exam room, but what about after a full day of work, after lifting, after repetitive overhead activity? The examiner will ask something like, does the veteran report pain, fatigability, weakness, or lack of endurance that significantly limits function with repeated use over time? If the answer is yes, they're supposed to estimate what your range of motion is had you been doing repetitive motion throughout the day, like at the end of a workday. And this is huge. Let's say in the exam, your shoulder flexion is 130 degrees, but you tell the examiner at the end of the day, after I've been working all day, my shoulder is so sore and weak that I can barely lift it to 90 degrees. They are supposed to document that. So when they ask about how your shoulder performs over time, give them real examples. Examples like, after working an 8-hour shift, I can barely move my arm. By the end of the day, my shoulder is so tired, so fatigued that I cannot lift anything anymore. Or after mowing the lawn, my shoulder will actually seize up and I cannot raise it for literally days. Now, section 3D is about flare-ups, and it's the same deal for flare-ups. If you're not having an active flare-up during the examiner still needs to ask you what it's like during a flare-up, such as how much can you move your shoulder during a flare-up? And during a flare-up, you say, I can barely lift my arm past 45 degrees. The pain is so bad, I can't even get dressed sometimes. This is supposed to get documented as an estimated range of motion during a flare-up. Again, all of this matters. All of this affects your rating. So after the range of motion testing, the examiner is going to do some specific physical tests to evaluate different shoulder conditions. So I want to walk you through the main ones. So section 6, which is the rotator cuff test. If you have a rotator cuff condition, like a tear, tendonitis, impingement syndrome, they'll do these specific tests. They look for what's called the Hawkins impingement test. What they do is they raise your arm to 90 degrees forward, they bend your elbow to 90 degrees, and then they push your arm down. Internal rotation, right? And a positive test is when they push that arm down and you have pain. That is going to suggest rotator cuff problems. You can do this at home. And if you think you have a rotator cuff problem, if you do that, push it down, you feel pain, you might want to be evaluated. Next is what they call the empty can test. Just like you're holding an empty can, you raise your arm to 90 degrees to the side, you turn your thumb down, like you're essentially like you're taking the can and pouring it out, right? And the examiner then will push down while you resist. So they arm out and they push down while you resist. If you have any weakness, that's considered a positive test. And it suggests specifically the supraspinatus muscle tear, which is one of the rotator cuff muscles, or potentially tendonitis of that muscle. And then the next test is the external rotation strength test. So you put your arms at your side and the elbows are bent at 90 degrees. Then you rotate your forearm outward against resistance. So someone's going to hold your hand and you're trying to rotate outwards. If you have any weakness, that suggests, again, rotator cuff infraspinatus tear or tendonitis. The next test is called the lift-off subscapularis test. Put your hand behind your lower back. You push your hand away from your back against resistance. If they detect any weakness, that suggests a subscapularis tear, which is another muscle of the rotator cuff. These aren't painful torture tests. They are just diagnostic tests. But here's what matters. If they hurt or you feel weakness, you got to tell the examiner. And then section 7 is instability and dislocation test. So if you've dislocated your shoulder or have any instability, they're going to do what's called the apprehension test, where what you'll do is you'll lie down on your back. The examiner will lift your arm to 90 degrees and rotate it outwards. If you feel your shoulder is about to pop out of socket, that is what they call a positive test, and you have to let them know. If you have recurrent dislocations, meaning you have multiple dislocations over time, you need to tell the examiner, how often does it dislocate or sublux, which is partial dislocation? What triggers this dislocation or subluxation? Do you guard all arm movements just so you don't get a dislocation? Like, do you hold it in and protect it? Then section 8 is looking at the collarbone, the clavicle, and the AC joint, the acromioclavicular joint. If you have any AC joint separation, meaning the clavicle separating from the shoulder blade, or a clavicle fracture, or issues in that area, they're going to do the crossbody adduction test. So they're going to raise your arm and bring it across your body toward the opposite shoulder. And then if you have pain in that AC joint, that's considered a positive test. If you have clavicular malunion, which means a healed but crooked bone, or potentially even AC separation, where they're not lined up properly, the examiner will document the severity. They're going to document things like pain, crepitus, as a grind, is there any tenderness? And then throughout the examiner will check for, that crepitus, the grinding, clicking, or popping when you move your shoulder. The tenderness, they'll press on different parts of your shoulder. If it hurts, just tell them. And then they're looking for swelling or deformity, any visible changes in the shoulder structure. All of this will get documented in that DBQ. Then section 4 of the DBQ covers muscle atrophy, meaning muscle wasting. So if you've had a chronic shoulder problem, especially a nerve injury or long-term rotator cuff tear, you might have visible muscle loss in your shoulder or upper arm. The examiner will measure the circumference, the diameter of your arm, with a tape measure and compare it to the normal side. If there is a significant difference, that indicates atrophy due to your condition, and that will increase your rating. So if you've ever noticed your affected shoulder looking a little smaller or maybe weaker, you need to mention it so they can measure it. Then next is the section 15. It asks about the functional impact. Very important section. Essentially, how your shoulder condition affects your ability to work and live life. This is your chance to paint the entire picture. The question is, does the condition impact the veteran's ability to perform occupational tasks? Examples of what you should say. I can't lift boxes at work. I can't reach overhead to stock shelves. I can't carry my toddler anymore. I can't wrestle with my kids. I can't do overhead pressing at the gym. I can't paint or do home repairs. I can't throw a football with my kids. I can't play catch with my kids. I struggle to wash my own hair or put on a jacket because of the pain. The more specific that you give, the better it becomes, right? Like, I used to work construction, but now I can't lift a hammer over my head anymore without severe pain, so I can't do construction. That gets documented, and that becomes your evidence. Now, the next section is section 10, and it asks about any surgeries you've ever had on your shoulder. If you've ever had any surgery, they're gonna look things for like, did you have surgery on maybe a rotator cuff repair? Did you have that labrum or a labral repair? What about the AC joint? Did you have any AC joint reconstruction, any total shoulder replacements, or any arthroscopic surgery? Tell them the date and type of surgery. If you still have residual problems after surgery, like pain, weakness, limited range of motion, make sure that's documented. A shoulder replacement, for example, has a minimum rating of 30% for the dominant arm and 20% for the non-dominant arm. But if you have ongoing severe pain and limitation of motion, it can be rated even higher. So here's what you should be bringing to your C&P exam. I know you've already submitted all your records and you submitted all your evidence, but you should still bring summaries of your medical records, right? You should bring summary of your service treatment records showing the injury, things like your blue button report or your VA medical records, private medical records like orthopedic visits, MRIs, x-rays, any imaging that's ever been done, or even physical therapy notes, chiropractor notes, acupuncture, anything that you can bring. But bring summaries, don't bring the whole stack, and highlight and circle the things that are specific for your specific condition. Another thing that would probably help is a written timeline, similar to a cover letter or a cover sheet. So what I recommend for veterans to do with this timeline or cover sheet is write down when the injury happened, and how it's progressed over time, and what treatments you've actually tried to date. The next thing you should bring is a list, a full list of all of your functional limitations. That way, when they ask you the questions, you don't forget a single one. So write down every single thing your shoulder prevents you from doing. Think about things that it prevents you from doing at home, at work, or in your daily life, period. And the next thing is, I know you probably have had buddy statements or a spousal statement. Bring those with you if you have one. You might not have one, but if you do, bring those, because sometimes they're supposed to look at those ahead of time, but if they don't, you can give them the opportunity to look at it in the exam. So this is anyone who's ever witnessed your limitations and can write a statement. And if they do, just bring a copy for the examiner. They're not required to use it, but most of the time they'll say thank you and look at it anyways. Next is if you've had a nexus letter or a private DBQ done from one of your private doctors or a private medical provider, or say from Xterra Health. But this is going to be a medical opinion or the DBQ that's been written down, and it's that specific medical provider's medical opinion about that condition. Now, you've already submitted it as evidence, but you still want to bring it in case they missed it when they were reviewing before they saw you. Next thing, if applicable, if you have them, as I recommend bringing photos or even videos on your iPhone. I mean, if you have visible deformities or atrophy or muscle decrease or swelling of any kind, if you've documented your limited range of motion, that's when you want to bring it, right? Don't assume. This is the biggest killer. Don't assume the examiner has seen any of this. You need to trust, but verify. Hand them the copy, circle, highlight the pertinent areas that you want them to see in real time. Now let's talk about what not to do in your shoulder C&P exam. Do not be late. If you miss your exam without a valid reason, your claim can be denied automatically. If you need to reschedule, you just need to call at least 48 hours in advance to let them know. Also, don't minimize your pain. This is not the time to be tough. You're not trying to pass selection here. You're trying to get an accurate rating for a service-connected disability. Also, don't exaggerate or fake it. The examiner has literally seen thousands of shoulders. They know what real limitation looks like. Don't pretend you can't move your arm if you can't, but also don't pretend it doesn't hurt when it does, okay? Don't let the examiner move your arm past the point of pain. When they do passive range of motion, if it hurts, just say yes, stop, it hurts. You're not trying to please them. You're trying to show them your actual limitations. And then don't leave without asking, did you document my pain? Did you write down my functional limitations? You can ask to review their notes at the end if you're concerned something was maybe missed. Don't expect a diagnosis or treatment at the end of your C&P exam. The examiner can't tell you your rating either. They cannot prescribe medication. They cannot refer you to a specialist. That is not why they're there. That is not their job. Remember, they are there to document. So after your exam, the examiner will submit the DBQ to the VA. You won't get a copy automatically, but you can request it through the va.gov or through your VSO. It does take a long time to get though. You can review it when you get it. If something seems inaccurate or missing, you can submit a statement to correct the record. The VA rater will use that DBQ along with your medical records, nexus letters, or any other evidence to assign your final rating. If your rating comes back lower than you expected, you have a couple options. Do not think that's automatically the end of it. You can file a supplemental claim with new evidence that you thought they maybe missed or be pertinent to your case. You can request for a higher level review, thinking maybe they messed it up, or the big gun, appeal to the Board of Veteran Appeals, but that takes quite a long time to complete. But the best strategy is to get it right the first time by being diligent and being prepared for your C&P exam. So look, your shoulder C&P exam doesn't have to be a mystery. When you know what's coming, when you understand what the examiner is documenting, when you can clearly communicate your pain and functional limitations, you give yourself the best shot at an accurate rating. And if you need help building your claim before your exam, if you need a nexus letter, a private DBQ, or a comprehensive medical evaluation, that is what we do here at Xterra Health. We are physicians and medical providers who specialize in VA disability claims. We know the DBQs inside and out. We know what the VA is looking for, and we help veterans build medical evidence and medical evidence packages that actually get approved. Head over to xterrahealth.com and schedule a free consultation. We'll review your medical records, figure out what evidence you're missing, and help you put together a claim that reflects the true severity of your shoulder condition. We have a 96 approval rate, physician-led, veteran-focused. If this video right here has helped you understand what to expect in your shoulder C&P exam, I want you to hit that like button and subscribe to the channel. And also drop a comment below. What's your biggest concern about your shoulder exam? What questions do you still have? And share this video with another veteran who's about to go through a shoulder C&P exam. Remember, knowledge is power, and the more prepared you are, the better your outcome. So thank you for watching, and until next time, stay mission ready.